Good morning, good afternoon, and good evening to all of you who have dialed in for this GS1 Healthcare webinar. My name is Els van der Wilden. I am Director Healthcare Providers at GS1 Global Office. And it's a privilege for me to welcome today you as an audience from a global community, and also our two speakers, Mr. Simon Moores and Mr. John Cotter from St. James's Hospital in Dublin, Ireland. And they will share with us in this webinar how St. James's Hospital is leading global innovation in healthcare, and how St. James's Hospital has started a journey to step-by-step adopting GS1 standards in several of the hospital processes. First, I will share with you a bit of the housekeeping. If we can move to the next slide. GS1 hosts these webinars every month. All attendees will be on mute, and please, if you have any questions during the presentation, type them in the questions area of this webinar. We will monitor the questions and answer them at the end of the call, and in case we have got more questions than time left, the questions will be answered later by the two presenters. After the webinar, the recording of this webinar will be posted on the GS1 Healthcare website, probably end of this week or latest beginning of next week. In that area, you will also find all our previous webinars, and feel free to share the link with whoever you want to share it with, because our webinars are a source of information for many people and are free to be used. On the next slide, we show you why GS1 is organizing these webinars. We have a focus on thought leaders and adopters of the GS1 healthcare standards from the global clinical provider environment. And the final goal in clinical environments, and also the final goal for us in GS1, is to improve patient safety, cost efficiency, and staff productivity through the implementation of GS1 standards and the use of GS1 identifier keys in healthcare. And we share and discuss, we identify projects and case studies, and we share this as a source of expertise and advice. And as I have come to know the work in St. James Hospital, they fit really in all of these categories. On the next slide, we show you a little bit about the activities that GS1 Healthcare does specifically to promote the work of healthcare providers. First of all, as I already mentioned, our monthly webinars, and all the information is on our website. And secondly, twice per year, we have a global healthcare conference as GS1. And we have at the Global Healthcare Conference a specific session on awards. One is the Provider Best Case Study Award, and the other award is the Provider Recognition Award. And the Provider Recognition Award is an individual award, while the Provider Best Case Study Award is an award for the achievements an organization has reached. And the one that is awarded will receive travel and accommodation to attend the next healthcare conference, and will also have the opportunity to present its case. And our next global healthcare conference will be in Bangkok in Thailand from October 31st up to November 1st this year. And we expect to have a significant number of healthcare provider speakers on our agenda. With that, I have come to the end of our housekeeping, and I would like to give the floor to our two speakers. Welcome, Simon Moores, and welcome, John Cotter. Please introduce yourselves and proceed on with this webinar. Thank you.
Thank you, Els. My name is Simon Moores. I'm the Director of Finance in St. James's Hospital.
And my name is John Cotter. I'm the Programme Director for Activity-Based Funding at St. James's Hospital.
So today I'll do an introduction, John will go through the detail of scan to surgery, and I'll finish off with certain key challenges that we do have. I suppose just to set a bit of context, St James's Hospital, for those who aren't aware, it's a 60-acre campus. We spend around 414 million gross expenditure per annum. We have approximately 1,000 beds with sort of 25,000 inpatient discharges per year, 48,000 day cases, 280,000 OPD attendances. We are a large academic teaching hospital, very closely aligned with Trinity, which is a college here in Ireland. And we have a sort of focus on innovative projects, and we've got a culture of fostering innovation, especially with sort of key stakeholders like the Wellcome Trust. We also have the national blood budget for haemophilia, and we're a national cancer centre, as well as having a lot of national specialties, for example, burns and medicine for the elderly. So we do have a lot going on the campus itself. In terms of where we are going with the campus, there's significant investment being placed within St James's and also on the campus. There is, we're almost creating a health and life sciences campus with the development of the Mercer Institute for Research on Aging, and also the new National Children's Hospital there is going to be built on the campus of St James's. The MESA building, which is the Mercer's Institute, is a 7-story building dedicated to aging, and very much RFID enabled and is a flagship in terms of the standard of what we're expecting any future developments for St James's sort of to achieve. In terms of the hospital itself and process improvements and innovation, we've been implementing GS1 standards for quite some time. Some of it is reactionary, but a lot of it is proactively chasing sort of the best practice and using GS1 standards to achieve that. So as you can see from the slides, from 1995, we sort of really focused on master data and ensuring that we have a structured coding to sort of base everything off. We then, in 2003, 2004, we had the haemophilia track and trace program. Again, that was born from the tragedy and very much reactionary, needed to control the use of blood and blood products. So we've significantly moved that forward. In 2008, the hospital looked at wireless Kanban for ward stock management. In 2011, we were the first hospital to pilot the surgical instrument track and trace. Again, born out of a CJD scandal that we really needed to be tracking our products. Again, we implemented GS1 standards to achieve this, and we've been a leading light since then. In terms of 2012, this is where we sort of really started to push the innovation, and we sort of went electronic procurement, very much driving the standards there and doing electronic data interchange. And then in 2014, we achieved this with go live of a key supplier, CRIN, end-to-end electronically. Again, we're constantly trying to onboard suppliers around this sort of innovation, and it's one that we need to focus on. Then today, part of the story is Scan for Surgery and our go live story on Scan for Surgery, which John will talk us through. We also have RFID tracking of precious samples, which is live. And then the future and the next projects, roll out Scan for Surgery, RFID tracking of patients, and very much patients' assets and staff, and really sort of using GS1 to sort of underpin all this future development. We've also done significant amount of case studies and white papers, of which we've published a lot. So we've got a very good base within the hospital in terms of skill set and capability to really deliver on achieving and understanding what it means to achieve the GS1 standard. So again, it's very much the evidence is there and it's in the domain. In terms of locally and internationally, we've hosted several local suppliers, and internationally we've brought over different delegates. As you can see, the Australian government have come over, the NHS have come over to see what we've been doing, both in using GS1 standards, but particularly Scan for Surgery and other elements of the innovation that we've done. In terms of the overall vision using enabling GS1 standards, you know, our aim is to use the right product in the right place at the the right person at the right procedure in real time and automate it as much as possible. I think using the GS1 standards, we will achieve this, and we've really started to make gains forward in achieving this. And it's a lot of hard work and dedication from several different departments has enabled us to do this. In terms of our ongoing projects, like I said before, our re-procurement is the infrastructure there is now in place to do electronic data interchange, and that's something that has been successfully implemented with one supplier, and we're onboarding several different suppliers. The haemophilia track and trace, a lot of you may be aware of James has been at the forefront of haemophilia and ensuring that we're actually using GS1 standards for that. We're in mobile technology. You know, a lot of the patients have apps and they scan the products in and out. In terms of the instrument track and trace, again, James has a lot of skills and capabilities there, and we use this on a regular basis in terms of tracking instruments in and out of theatre. Scan for surgery, John will go through. An exciting one for us is also the automatic tracking of RFID, using RFID and tracking the precious samples and vulnerable patients. Again, this is something that we're investing in constantly, and will be sort of developing up our skill set and our ability to sort of really leverage off the data that comes from being able to track the assets and the medical devices and what have you. In terms of the other projects that are ongoing, rollout of further to Scan for Cath Lab, which is sort of the next phase of Scan for Surgery that we're looking to develop up, and also the RFID side, the infrastructure we're investing in, as I said, and really looking at leveraging off that for medical devices. So we're really it's really showing, using GS1 standards, that we've got a lot of projects ongoing. We've got a lot of projects there that we've had going for a long time, and we're really trying to make it a healthcare campus that is based on GS1 standards of automation and sort of making sure we achieve that. I'll now pass you over to John to go through the Scan for Surgery.
Thanks, Simon, and thanks to everybody for joining the webinar. And so briefly, I'm just going to talk you a bit further through our Scan for Surgery program. So what has been involved and how we're using GS1 standards to improve efficiency in our theatres, both across the products that we use and how our theatres operate. So as a general overview, if you can see on the slide, this is how our operating theatre is set up. We have a number of different caregivers who have barcoded name badges in the theatre. We also use the GLN as the identifier for the location of the theatre. And what we've begun to do is to track and open individual patient records using the patient identifier, and then scanning all products used to that patient. So we're capturing the manufacturer barcode on each of the projects used, and we link that to the individual patient. And our reason for embarking on this journey was for three different reasons. We identified benefits that we could achieve in three areas. So firstly, in the area of operational efficiency, what we wanted to do was to automate the product supply chain, and particularly for our nursing colleagues. So a lot of time was spent by nurses in different inventory management and supply chain activities. What we wanted to do was introduce scanning technology that would automate that process for them. This, in turn, would make additional time available for patient-centric activities. And what we also wanted to do was hold managed minimum inventory levels at a theatre level, so to reduce the level of stock that we have outside the theatres. In the area of patient safety, we also saw huge benefits could be achieved in the area of product traceability back to individual patients. So in the case of a recalled product, what we hoped to do was digitally link all those products to the patients, which would make recall much more efficient. We also wanted to get early identification of expired products and to hopefully take them out of the supply chain before they could be used. Then finally, in the area of patient-level cost analytics, this is a huge topic for us in Ireland. We're moving to a new funding model, similar to that in the NHS and also in the Netherlands. And a huge challenge for us was understanding the cost of a procedure. We will now be funded at a procedure level, but we had very little understanding of costs at a procedure level. A lot of the data that we took in the past was that we had a minimum amount of data, and we made a lot of assumptions about financial data and how we apportioned it to different procedures. The impact of that was we weren't really sure whether we were being appropriately funded for the different procedures carried out at the hospital. And this was really important for a hospital like St. James's, because we deal with a lot of complex surgery at the hospital. So with this data, what we hoped to do was to improve data analytics for decision making and for funding decisions as well. So I can take you through that a little bit further on the next couple of slides. Just to mention, so what was a huge thing for us, and some of the key enablers for this project, was we took a multidisciplinary approach from the very beginning, and we really engaged with a lot of stakeholders in the hospital. So, for instance, the Scan for Surgery program drew on a lot of expertise from a lot of different areas, because it touched a lot of different areas in the hospital. So within our program, we had two different groups that were set up from a governance perspective. We had an oversight group and a working group. And on those two groups, we had representatives from nursing, both in and outside theatres. We had representatives from finance, representatives from our IT department and solution provider. We also had logistics representation, obviously, and then what was key was consultant representation, so clinical representation from both the consultant and the nursing body to really drive the program forward. What we also did from the very beginning was to get hospital executive buy-in and to get sign-off on the program. So at the very beginning, we produced a very detailed business case, which went through finance and logistics before being signed off ultimately by the hospital executive and the CEO. So as a hospital, I think we've really embraced the adoption of GS1 standards over the last 2 years, and it was really going on from the other successes that we were able to successfully introduce the business case and then ultimately the program which followed. So what were also key enablers for us, as we saw, was continuous communication with all those different disciplines, and we really concentrated on this from the beginning, and hopefully got a coordinated effort and feedback from all the different disciplines. And we had regular meetings where people could voice different concerns about how the system would operate and ultimately how the new supply chain would operate. And that's still an ongoing feature of the program. What I've highlighted in red here in key enablers was two of the big enablers for us. One was a robust integration between our existing inventory management system, which was SAP, and also master data was hugely important in this. Initially, when we started the program, we thought we had good master data that would enable the adoption of this project and this system. When we actually looked at it, what we had was a lot of good data and some bad data at a PAC level or a case level. In order to enable us to introduce the solution, what we needed was master data at the individual unit of use level. And what we found was it was very hard to get these details, particularly from suppliers. And so we had to put in our own resources around this. This is still an ongoing challenge for us, and Simon will speak more about that in a few minutes. So from our business case and from the outset, what we tried to do, and what hopefully I'll show you now, is that we tried to get a measurable reduction in nurse time spent on inventory processes. We knew a lot of time was being spent by nurses on non-value add processes. So introducing this technology was really to reduce the amount of time nurses were spending on these. We also wanted to see a measurable reduction in the time to trace recalled products. And we also wanted to see clear reporting of procedure level costs versus funding. And that was really to ensure the hospital was receiving adequate funding from funding bodies. Also, what we want to do in time is see a measurable improvement or a reduction in expired product and aging product. I think we can only achieve this really with more engagements with our suppliers, and particularly with the barcodes that are placed on packaging. And also, what we have seen in the last number of months is a measurable reduction in inventory volume, which we can speak to as well. So, just to give you a bit more detail about the key enabler of robust integration, this, just for information purposes, is what our integration looks like. So we introduced the PowerGate system back in 2017. It's integrated fully with SAP across 4 message types, one being the master data catalog feed, which goes to PowerGate. And this contains all of the product information from price and also the identifiers down to unit of use GTINs. And so in turn then PowerGate operates a minimum or maximum inventory levels, and when these are breached, two messages are sent back to SAP, one to replenish stock back into the theatres, and also to issue stock as well to a particular area, which triggers a financial transaction in SAP. And also a goods receipt transaction is sent from SAP to PowerGate to identify products that have been shipped from our warehouse to the PowerGate system and to theatre. So following the robust integration and following the introduction of the track and trace technology in the theatre, so how have we done? So I mentioned one of the benefits we tried to achieve was around operational efficiency and reducing nurse time spent on supply chain activities. So before we introduced the track and trace system, what we saw generally was the nurses would spend 20 hours per week in their area, and these were clinical nurse managers, highly trained nursing staff. So they would spend 20 hours per week on different inventory or supply chain activities. Clearly they're overqualified for that role, and I would say they might not even be qualified for that specific role. Their background and training is in nursing, it's not in supply chain activities. So after we've introduced the scanning system, we've now reduced that down to 2 hours per week in supply chain activities. And this is really around scanning products at the individual patient level. So to give you an idea of what this looks like, on the left-hand side of this slide, it shows the flow of the process in our theatres. So what happens is a patient will come into theatre, a new record will be opened up, and as the products are scanned, the product levels in the system will reduce down to a predefined level or stock holding level. When that stock holding level is breached, an automated message is sent to SAP, and then in turn SAP will look in the entire warehouse and the entire stock holding for the hospital. If there's stock available, then it will ship it directly back to the theatre. If not, it sends an automated message to a supplier. And what we're trying to do is onboard more suppliers over EDI, so it will be a fully automated process then. So after a message or a PO is sent to the supplier will then fulfill the order and send the order back to the theatre. So as you can see, what we've done is we've created a model where the patients or the products will be opened and scanned to a patient, and the next human intervention in the supply chain will be in the supplier's warehouse to pick the order and reship it back to the hospital. So what we've taken out is a lot of manual tasks. So before we introduced the system, the nurses were engaged in activities like stock counting on a daily basis to see what stock was available. They would also have to manually create requisitions and maybe purchase orders to send out to the supplier. They would have to chase up with the supplier on older orders to see when they would be received. They would have to chase up with line managers to release orders. There was a lot of manual tasks involved and a lot of phone calls involved to see exactly where in the supply chain different products were. So what we've done now is, by fully automating that, we've reduced all of those tasks. And as you can see on the right-hand side, per theatre, what we've done is to reduce it from about 10 hours of activity per week down to 1 hour of activity per week for nurses. And that 1 hour is mainly made up of scanning products at the patient level. In terms of cost analytics and cost analysis, back before we introduced the system in 2015, on the left-hand side, this was the level of data that we had. So for our theatres, we could trace approximately 4% of our total cost directly to patients. And that 4% was mainly made up of really high-value implants that we used in the hospital. So on an annual basis, we used to receive a spreadsheet from certain theatres to say that patient X has received this implant, and we'd assign that cost directly to that patient. When you added up all of that data that we got back from theatres, it represented about 4% of the total cost of theatres. Since introducing the Scan for Surgery system, however, back in 2017, what we can see is we can trace 89% of costs now directly to patients. So as patients come in, we're scanning all products used at an individual patient level. This is all digitally recorded, so we have full access to that, which means we can trace 89% of our theatre costs back to patients. So in terms of cost analysis, this is what that level of data will give to us. So as you can see, this is a snapshot of some of the data that we've taken from our theatres in St. James's. This is a cardiothoracic theatre that we're showing now. So as you'll see in the bar charts there, we have a number of different procedures, and this one I'm showing now is a coronary artery bypass that we've done. So the blue bar is showing our total product cost in that area, and the red bar is our total pay cost. We can drill into that and see that cost by consultant then, and we can also see average cost by consultant. So what we can do is very easily compare different costs across consultants or across the procedures, and then try and find outliers to see if there's any areas that we can make savings. What we can also do on the right-hand side then is to link that data to our overall patient demographic data, so we can see the complexity of the patients who've passed through the theatre, how many patients we're talking about, which is 122 in this case, and what their average and median lengths of stay are. So we've very rich data now in terms of our theatre and the cost in theatre. In terms of patient safety, we identified at the beginning that we could significantly improve our process for recalling. So Ireland hasn't been immune to some of the large-scale recalls that have happened in the past few years. In the case of the Dupuy hip scandal, we had 3,500 hips recalled. There's also some other high-profile recalls that have happened in the past 12 months across pacemakers, and also another big one in the hip breast implants, of course. So traditionally, what we've done and what happens in many hospitals is we've traced those products back to patients using a theatre book or a diary system. So where an implant has been given to a patient, we peel off the sticker from the implant and place it in a diary along with the patient details. So this obviously isn't very secure to start with, but it's also very hard to trace then back to the patient. What we've replaced that with is a digital record for all of this. So we're scanning digitally all of the products used and linking it to the patient. And what we get instead is a much easier way to trace. So what I'm showing here is in the left-hand table a product listing of everything that's been scanned. I can easily type a search item in, or I can type a GSIN in or a serial number in. In this case, I'm typing in a valve to identify heart valves that have been used in our theatre. When I select that, on the right-hand side, it very quickly returns me a list of patients who've received that received a heart valve, what theatre they were in, what date they received their operation, what consultant they were under, what item they received, and how many they came into contact with. And so we can do that across all of the scanned items now. It's very quick. It happens in a matter of seconds. It can be down to the suture level or the dressing level if it's needed. So we have a very, very robust and very quick way of recalling products to patients. So I hope that gives you an overview of some of the benefits that we've seen and some of the different aspects of the project. I'm going to hand you back now to Simon, who will just go through some of the current challenges that we face and then some of the places that we're going as well with this project.
Thanks, John. In terms of the current challenges, we sort of have an ask mainly of the supplier market. You know, at the moment, currently, we don't have a single repository for product data at a unit of use level. A lot of the time, it's almost a case of a single product versus the pack, and that causes an issue being able to sort of leverage off the infrastructure that we've developed up and causes major issues to actually capture the GTIN. It's a manual process at the moment, and that's something that we sort of really need to address in a collaborative way to try and work out how we get the GTIN from the supplier. At the moment, we have a currently dedicated resource required to deliver the GTIN level. So ideally, the big ask is that we really need to receive data directly from the suppliers in order for this to be a scalable and a sustainable model. Just to give you a bit of context, in 1984, the Article Numbers Association of Ireland sort of had a meeting, and this is in 1984. They pointed out the difficulties faced in introducing barcodes to retailers, and they basically said products would need to be 100% barcoded, manufacturers must put the barcode in the correct place, and suppliers must notify traders of the barcodes on their products. And this has been the biggest problem that was caused endless waste of time, and that was in 1984. Unfortunately, in healthcare today, we suffer the same problems that was in retail 35 years ago. I think really sort of working towards this sort of retail solution would deliver a lot of benefits for both suppliers and also the healthcare environment. I think, how can suppliers help? Again, what we ask for is barcode on the case, barcode on the inner, and sharing of the product data. They're the three takeaways in terms of what we were asking for the supplier. In terms of what's in it for me, both at the hospital level and supplier, reduced inventory holding costs. So we can see a much more lean holding of inventory. We can see meaningful consumption data so that we can understand what levels we actually need. And the biggest one is product research and development data. This is an area that's not been explored, but something that we should definitely be focusing in on, in so much as the data that we have can be used to influence what we do in the future. I think improved health cost analytics will drive a lot of this, and better product traceability, which will ultimately lead more time for patient care. I think just another example of the challenges is the cost benefit. You know, it was easy for us to articulate the inventory balances and how they've reduced over a time period. We've measured that. Now, it may not seem that large, and to be honest with you, from my perspective as a director of finance, I haven't gone after levels of inventory because there's a cultural piece where the nurses and the theatre staff have often seen stock on the shelves. So if you start suddenly reducing that, they start to get nervous. So there's a bit of that's not the biggest win for me as a director of finance. It's really all about ensuring we're going in the right level and we've got visibility and we can start to use the information and reduce it in a controlled way where there's buy-in and we're not about stock reduction. Also, one of the surprising elements that has come out of this is that the average patient cost has reduced, and the cost, and that is purely down to cost visibility. So the nurses are scanning the products and they're seeing the price of the products. So it's meaning that they're not opening everything that they would usually open if they don't have to. And that cost consciousness is just being seen. And it wasn't something that we went after, it was something that we're seeing naturally. And again, it's sort of good housekeeping. In terms of what our next steps are, refining and sustaining the operational model. For us, there's a lot of change management that we need to go through internally around the supply chain. And it's about engaging people and making sure there's a comfort in that if we're going to introduce a model, it is sustainable and it actually doesn't cause any stock outages or anything like that. So, you know, it's really important. We're also looking at rolling out the solution to other high cost areas. So we're very much looking at cardiac cath lab, as like I mentioned. That's something that we're really looking to do. Improve data sharing across the entire supply chain. So if we can get to a situation where everyone can see stock levels and can see costs, then it will start to show improvements in patient flow and in sort of allow us to do a collaborative piece with the supply market. And I think, again, we're looking at integrating what products we're capturing into the medical record, so that when the clinician opens the medical record to start documenting information, a lot of the information around the product type is already there within the medical record. So that's something we're definitely looking at doing. And I think that sort of brings us to the end of the presentation. And I suppose, Els, it's sort of, is there any questions?
Yes, Simon and John, thank you very much for presenting this excellent case. And we have received some questions, and I will pose the most intriguing one first. And that was a question to John. John, how did you actually get Simon convinced, since Simon is responsible at the end for all the finances? How did you get him convinced? Because at the start you would not have, possibly you would not yet have any revenues. So could you elaborate a little bit on that?
Yes, it's probably a question for Simon and how I convinced him, I would say. But I suppose if you, at the beginning, if you look at the retail model, intuitively you would think that a lot of investment has gone into retail and into reducing the costs in retail across the last 10, 15, 20 years, and to introducing complete automation across the supply chain, from the Tesco's of the world to the Amazons to the Walmarts of the world. And a lot of it is built on automation and scanning technology. So it's not a huge leap for any finance director to understand that there's going to be benefits in this area. From our perspective, we obviously had a culture of adopting GS1 standards and adopting track and trace technology in the hospital. So that also played a part. The successful implementations of the past had played a part in our willingness to adopt it. But I suppose the biggest thing was before we embarked on this, we knew we had a gap in our understanding and in the information that we needed to manage costs effectively in theatre, in our high use area. So previously, to give you an indication, we previously did one stock take per year in theatres, and that was our complete visibility of how much stock we were holding down in theatre. And then what we did was we asked nurses on a part-time basis to manage the level of inventory. We never really knew how much stock we were holding down at a theatre level, which I suppose everybody will admit to now. We didn't have that understanding. And so it's very hard to manage something that you can't measure in that way. So I think we had a compelling case from the beginning. We knew that we had a gap in our understanding from a financial point of view. And so from that perspective, it was very easy to identify, even conservatively, we knew we could probably make 5 to 6% savings on our inventory balance. And when you look at it and what we've done in the meantime, outside every 2 of our theatres, or outside which holds stock for an area, we're carrying approximately €850,000 worth of stock outside 2 theatres. So previously that was unmanaged, and even from a conservative estimate, if you put some technology in around that, you know you're going to produce savings of about 5 to 6%. So I think from that point of view, the case study kind of sold itself. But maybe from Simon's perspective, he might be able to say what it was for him.
I think when it was, you know, when the business case came to me to review, it almost stood up on its own merit. The stock management, the identification, and the cost visibility really sort of stood out from the case in terms of, especially with the investment. Now, the investment was very much in the individuals. We have a lot of knowledge. You know, Pat Bailey, you know, has worked in this space for a long time, and you know, Vincent Callan. There's a lot of people there that would have worked in this GS1 space for a long time, and so we had a lot of the internal skills to deliver the project. So what we were looking for was individuals to sort of capture the data. So the investment wasn't so significant that it was such a risk. But you know, even when looking at the business case, you know, the patient safety and freeing up the nursing time, you know, even though it's something that I wouldn't normally look at from a pure finance perspective, the benefits for the organisation as a whole absolutely stood up on their own merit. And you know, when you look at the finance, the stock levels, and again, I go back to what I mentioned around managing the stock levels, and it wasn't about reducing stock levels to release savings. That has automatically come through natural just visibility and people understanding the turnaround time, you know. And the other thing to say is that by scanning at the point of care, it gives you a level of visibility. So if a product comes into the theatre that would never, you know, that nobody has any idea on, a rep decides to come in and sort of say to the consultant, look, this is a new, they can't order the products because they can't scan the barcode because it's not in the system. And therefore it gives you an automatic level of control that allows you to really sort of have the comfort that we have controls and processes in place that if a new product needs to come in, it needs to come in the right way. So there's added benefits there as well, that, you know, it really sort of helps with that control in the theatre environment, which we haven't had this level of sort of visibility on for forever. Like, so it was sort of a business case sort of stuff. So it didn't take much convincing, to be honest.
Okay.
Sure.
Thank you very much. We've got quite some questions, so I will try to manage as many of them as possible. One of the questions was, what do you do? How do you manage products that are not GS1 identified when they enter your hospital? Maybe you could share something on that.
Yes, so that was a huge problem for us, and it took a lot of time to work through, both with the supply chain and logistics people and the nurses as well. So there are some products on our that we manage through HPAC identifiers as well, and they're contained within the systems as an identifier against that product. And so they'll obviously scan in the system, and it's managed through the same process. But then in our theatre, there were approximately, I think there's approximately 150 items that have no identifier at all at the unit of use level. Now, in individual theatres, it probably amounts to about 80 items that they would use in that theatre that wouldn't have an identifier. So what we've done is we've created our own catalogue for those items. And that catalogue sits physically on the wall in theatre. So when one of those items is used, the nurse will scan the barcode in the catalogue on the wall. And I'm not sure if it's the same in other jurisdictions, but what we say it kind of closely resembles is in a grocery store or in a shop somewhere. If you buy something like a bread or a pastry that doesn't come in specific packaging, often what they'll have at the checkout counter is a catalogue or a wheel with barcodes that identify that item. So our catalogue is very similar to that in nature. It sits on the wall in the theatre, and we scan that catalogue as a proxy for the barcode on the product.
So in fact, you also say that for these products that you catalog on your own catalog, you will not be able to have a direct link to the supplier, be it medical devices or pharma supplier.
So we do in that the integration in our systems is across our internal catalog number. So we've set up an identifier ourselves for that, but we transact with the supplier across a catalog number or a manufacturing part number. So that's the identifier used for trading, rather than we're not at the stage yet where we trade across different identifiers that are across some products and some suppliers. So it's kind of it's a combination, I suppose.
Yeah.
Okay,
thank you. Another question was if you have applied a track and trace system also for pharmaceuticals.
The answer to that is no, but it is in the plans, I would say. Time might know more about that.
Not yet is the answer then.
Yeah, we do it for blood products. We do it for blood products, and that's the haemophilia. But that's at the moment that's the only scanning of pharmaceuticals that we actually do, as far as I'm aware. So I caveat that.
Okay, thank you. That's a good addition. Another question we received is if on your patient ID, do you use the GSRN as a patient barcode to link the patient also to the event?
Yes, so we use the patient MRN.
Yes.
So they're a unique identifier in our administration system. And separately, so what we do then is extract the information taken from the inventory management system, which is GHX's Powergate system. We extract it and then we combine it with other information from the various different systems across the hospital, using the MRN and the episode as the primary key identifiers to link all of the data together about the patient.
Okay, thank you. Another question that we received is if the units of use of master data are recorded internally, and if you give a GTIN at St. James, and then how the scan at patient of unit level will sync back directly to your stock. Could you explain a little bit on that? If it is too technical, please say also, because then we would have to answer these questions in a different way.
Yeah, I don't understand the question. Could you repeat the question, maybe?
Yeah, it's a little bit difficultly phrased here, but the question is whether if you scan a GTIN sorry, I moved too quick, so I now lost my question. Let me go back to the question. The core of the question is when you scan, how does it link back to the subsystem and then to your stock replenishing?
I think it might be a bit too technical to take today. I think the essence of the question might be around units of measure. So what we've done is we've built up a hierarchy of identifiers and units of measure within the Powergate system. And then the Powergate system transacts with SAP then based on that hierarchy. So it might, I'm not sure if I'm getting the correct question, but it might be one that we take offline, maybe else.
Yeah, okay, yeah, what you explained so far is how I understood the question, but I will link the question to you offline. Another question is, if you scan a GTIN on a pack of 5, for instance, you could document 1 package, 5 pieces, or 1 piece. That's also a little bit technical, but could you distinguish between these possibilities in the way you have set up the implementation?
Yes. So if there's a GTIN at a pack of 5 level, we'll never scan that to identify 1 as being used. So if you take one of the items out of that pack of 5 and it has no identifier on it, then that identifier will be created in the catalog.
Yeah, okay. Yeah, thank you very much. And you both were very clear on explaining that at the hospital level, St. James's is fully GS1 compliant. You scan GTINs at product level and you're ready to trade on EDI at GTIN and both GLN level. And you are waiting for suppliers to adopt the GS1 standards in GTIN on all levels of packaging and on the EDI trading. Could you explain us a little bit, are you waiting for the suppliers or are you also actively requesting the suppliers?
Yes, so we've actively engaged with a number of large suppliers over the last number of months, mainly the really large suppliers in a global sense. In Ireland, we find it difficult sometimes to get engagement because a lot of our supply comes through distributors rather than the original manufacturer. So what we're trying to do is build up a greater level of engagement with the suppliers, just to outline what the project is about and what we'd like to do in the future and what benefits could arise for all parties. And so we've been actively doing that. And another thing in Ireland, which we're looking at probably at a government or a HSE level or a wider hospital system level, is to fully introduce the use of GS1 standards into the procurement and contracting process. So it'll be a condition of contracting that identifiers are supplied to the hospital.
Yeah, okay. Do we understand correct then that, thank you for answering, but do we understand correct that then in future you will receive data direct from the suppliers from both pharma and medical devices?
Yes, that's what we are hoping for, yes.
Okay, yeah, thank you very much. We got a very nice question here, and that is, you explained very clearly what's happening in the operating theater, and you explained that there is more cost consciousness among the staff and among the nurses, but I also received a question on what has been actually the reaction of the surgeons of your track and trace, how you set up the scanning and the track and trace. Are the surgeons compliant? Do they understand the benefits? And how did you present to them this system? How did you get them engaged?
Yes, so it's been surprisingly, well, I wouldn't say surprisingly, but it has been very positive from the surgeon point of view. I think for everybody in the hospital, the kind of culture in the hospital has always been a cost-conscious culture and has always been an innovative culture. So when we presented the solution, and particularly when we presented the data coming from the solution, we got a huge amount of positive engagement from the surgeons and the consultants, because they really identified that there can be huge benefits where we can probably reduce some costs in areas. It will free up funding to spend in other areas. So they recognize that as a benefit. But also, I think a huge benefit for the theatre as a whole has been the surety of supply of products into the theatre. So there's a lot of the stress of last minute stockouts and a lot of the stress around getting products into theatre has been taken away from clinical staff in theatre. So there's a lot more time for patient activities, which I think they are seeing as huge benefits as well.
Okay, thank you. And do you use a complete separate system, or are you also using existing clinical systems to capture the data in theatre, like a theatre management system, for example?
Yes, so what we do with the inventory management system is to capture all of the product related information or data. and we use a theatre management system called Nexus to capture time and also to capture who has been involved in the procedure and what their role was in the procedure. So we link all of those data sets together, along with we have SAP HR, which records pay rates as well, so we can produce a very detailed cost analysis that way.
Okay, thank you. And do the clinicians use that also on clinical decision making, for instance, on a type of medical device they want to use?
We haven't had a huge, there's no one instance where I could say yes at the moment. We haven't seen that yet, but we will see that in the future. We're in the early stages of adoption, is what I'd say.
Yeah.
So it's continuously being adopted.
Okay, good. Another one on challenges is, do you still have challenges on scanning products in the operating room? And if so, what might be your top challenges?
So the top challenges in the operating room from a scanning point of view would be products that don't have an identifier. So that's a huge challenge for us. Also, products with an identifier that changes is a huge problem. So where we've been traditionally or continuously buying a product, and then all of a sudden the manufacturer changes the identifier on the product, but doesn't communicate that to the hospital. And that can also be a huge challenge because it simply won't scan. And there'd be no obvious reason why this will happen for the staff on the ground. And there might have been a slight change to the product. But the fact is that the information or the data around the product isn't flowing to the hospital in advance. So it means that the first indication that we have that there's a problem is the item won't scan in the theatre. So if you think about in a retail context, there'll be very few times when you'll go to the checkout and a product won't scan. And that's because the data has flowed in advance with the product to the retailer. And so what we're trying to do is to set up a system where we can achieve that as well and get the data in advance to cut out all of the problems or challenges we face around scanning.
The other thing I'd also say from an operational perspective is that whilst we sort of went live with theatres sort of 1 and 2, which is cardiothoracic, when we sort of look to move down the corridor, a lot of the challenges is the procedures are fast moving and the nurses are scanning the products. So a lot of the feedback on one of the challenges was that these fast moving procedures didn't give us capacity for the nurses to stand there and scan the products because they were doing other things, and it was sort of the, so we've really had to adopt almost like a shopping list sort of solution whereby one scan covers 3 or 4 different products and that then automatically reorders. It was just because we sort of adopted an agile approach with the rollout of this and sort of looking for feedback, constant feedback. It was very much, look, this is a problem for us, and that's sort of what we sort of, the nurses came back and told us. So it was very much, right, okay, how do we deal with that? And is a shopping list available to us? Can we start coordinating that to really sort of move into the different theatres? So whilst, you know, the platform and the infrastructure and the systems infrastructure is the same, the actual different, slightly nuanced work that's been going on in the theatres means that we sort of had to tailor the solution a little bit. But again, that was sort of everyone around the table, and that's why the project governance was set up that way, to really understand and facilitate the sort of speed at which we need to sort of respond, because there's no point us coming back 6 weeks later without a solution, without the nurses being involved in that solution. So that was another operational challenge that we sort of had to overcome.
Okay, thank you very much. Yeah, thank you very much for explaining. With that, I think we have come almost to the end of this webinar. And on behalf of GS1, I really want to thank you for sharing this excellent case with us. You shared about governance, you shared about a journey where you have really been able to proceed step by step. You shared about the different products you have already achieved results on in St. James's Hospital, and you also shared with us some of the future plans. And as you both made very clear, you've really achieved a lot, and still there is enough challenges looking at the future. With that, I would like to remind everybody that the recording of this webinar will be posted on the GS1 website, probably end of this week, latest beginning of next week. It is free for sharing, so please feel free to share. And I would like to thank the audience for dialing in and listening to this message. And I would want to give a big thank you to Simon Moores and John Cotter for spending time on sharing this excellent example with us. Thank you, Simon, and thank you, John.
Thank you.
Okay, wishing you all a very good rest of the day. Thank you. Bye-bye.